Hey everyone, it's Dr. Carmen Corder here with Health Ed Solutions, and today's lesson is on ACLS algorithms. Don't forget to visit us online at healthedsolutions.com to certify or recertify your ACLS, PALS, BLS, or NRP 100% online. Now let's get started. Now, when I teach ACLS to my critical care students, I break the algorithms down into two major categories. We've got dead patient algorithms and alive patient algorithms. The dead patient algorithms is what we're going to be talking about today. So we've got PEA and asystole, which are treated the exact same way. And then we have VFib and pulseless VTAC. So we're going to start off talking about PEA and asystole. Now you know that PEA stands for pulseless electrical activity, meaning that there is electrical activity being conducted through the heart, but it is not sufficient to generate a pulse. Your patient is in fact dead. So we're going to always start out our algorithms with high quality CPR. And now that means beginning with high quality chest compressions at a rate of at least 100 to 120 per minute. Now when I teach this in like mock code, when we're doing a simulation on codes or whatever, I teach my students to sing in their head, Another One Bites the Dust, kind of morbid, but it's a way to help you keep track and know that your chest compressions are in fact fast enough. Another thing I want to mention about chest compressions, not only the rate, but the depth, full 2 inches on the depth, and always allow for full chest recoil on your chest compressions. That will be tested over at some point. You will run into that. So we're going to start out with high quality CPR. We're going to start chest compressions. We're going to attach the monitor, take care of their O2. So we do that by the head tilt chin lift maneuver or the jaw thrust if we think that there's some kind of cervical spine injury. And we're going to bag them with a bag valve mask or ambu bag, whatever it's called at your facility or your school. And our ratio of chest compressions to breaths is going to be 30-2. All right. We're going to also make sure that they have an IV because we're going to be pushing meds. All right. So IV monitor O2. After 2 minutes or 5 cycles of 30-2, we're going to check a rhythm. And the way that we do that, we're going to check the rhythm on the monitor, but we're also going to check the pulse again, right? And where we check the pulse, right here at the carotid, no more than 10 seconds, y'all. We do not need to interrupt chest compressions for more than 10 seconds to be checking for a pulse, all right? So let's say we've still got PEA or asystole, we still don't have a pulse. Is it shockable? The answer is no. So the reason that this algorithm to me is a little simpler is because we're just going straight to the drugs, okay? We're not shocking. We don't have to remember, how many joules are we shocking at. We're just doing CPR and drugs. So the drug of choice here is going to be epinephrine, 1 milligram every 3 to 5 minutes. The concentration is 1 to 10,000 because we're giving it IV. Now we're going to give the epinephrine, and always, always remember to follow these drugs with at least 20 cc's of a flush. And if you're giving it in a peripheral IV, throw that arm up in the air because remember, this patient is dead. If we don't lift the arm up and allow gravity to help us get that drug down to the heart, it will not be circulated. Okay. So epinephrine, 1 milligram every 3 to 5 minutes. So, and then 2 more minutes of CPR. And we're going to begin considering an advanced airway. And by advanced airway, I mean intubation. Once your patient is intubated, then your breath to chest compression ratio no longer exists. All right. So your chest compression person is just going to be going at least 100 times a minute, up to 120. And the person that's delivering breaths is going to be given a breath 1 every 6 seconds. Okay. And you are not going to pause chest compressions anymore to give breaths once the patient is intubated. Something else that you also need to begin to consider are what we refer to as the H's and the T's. And these are our reversible causes. And I can tell you that after 13 years of being a nurse, almost the entire time I have worked in critical care, when my patient goes asystole or they go into PEA, the cause is almost always a PE or a pulmonary embolus. Now, under the H's and the T's, that's going to fall under thrombosis pulmonary. All right, so some of the other H's and the T's are hyper and hypokalemia. Those are huge with your dialysis patients who say miss a dialysis treatment and their potassium is 8.5. Hypovolemia, as in hypovolemic shock. Hypothermia, like maybe somebody who fell into a frozen pond or something like that. And then some of your T's, toxins, which would be your drug overdoses. And then, like I mentioned, thrombosis pulmonary and thrombosis coronary are some of your H's and T's. So that kind of wraps up what you're going to do for PEA and asystole. You're just going to kind of keep repeating this until we get our patient back. So next, let's talk about VFib and pulseless VTAC. Okay, so now we've talked about PEA and asystole. Let's talk about the other dead patient algorithm, which is VFib and pulseless VTAC. Now, don't get pulseless VTAC confused with VTAC with a pulse. I have had patients that are sitting there in VTAC, they're sitting up, changing the channel on the TV, talking to me. Those patients have a pulse. We're not going to start CPR on those patients. But if they don't have a pulse, we're going to treat them initially just like we did asystole and PEA. We're going to start high quality CPR. Our chest compression to breath ratio is going to be 30:2. And we're going to absolutely make sure that the monitor is attached as well as the defibrillation pads. We've got the O2 taken care of as far as they're getting bagged and we're seeing good chest rise and fall, and they have an IV. Now, the only difference here in the very beginning of this algorithm is after our first 2 minutes of CPR, we are going to check the rhythm. Again, check the rhythm on the monitor and check for a pulse. And if we still have, VFib or pulseless VTAC, we are going to shock this patient, defibrillate. All right. Now, in the 13 years I've been practicing, I've seen so many changes in ACLS. It just like makes my head spin. But now we're going back to what we call stacked shocks. So the first shock you deliver is going to be at 120 joules. And these are on the biphasic defibrillators that are in like probably 99.9% of the hospitals across the country. Biphasic means that they give electricity in 2 directions. Like you put one pad on the front, one pad in the back, and electricity is coming at that patient's heart from the front and the back. So the 120 joules is assuming that you have a biphasic defibrillator. All right, so you're shocking the patient. Here's the key. Immediately after the shock, immediately go back to your high quality CPR, your chest compressions. All right. We're going to do CPR again for 2 more minutes or 5 more cycles. And then we're going to again check the rhythm and check for a pulse. And if it is shockable, which you're going to hope that it is, we are now going to shock them at 150 joules. Remember when I said those stacked shocks? So the joules get higher and higher with each shock. So after we have shocked the patient twice, we're going to resume our CPR, immediately going back to chest compressions. We're going to start thinking about drugs now. So with our shockable rhythms, which are these rhythms right here, we're going to always shock twice before we even think about drugs. Whereas with asystole and PEA, we kind of immediately start giving drugs after that first round of CPR, of 2 minutes of CPR. So what is our first drug that we're going to consider? Always epinephrine, okay? Epinephrine, 1 milligram, 1 to 10,000. Throw that arm up in the air to circulate that epinephrine. The reason we give epinephrine is because epinephrine, again, has been proven to improve the patient's response to the shocks, all right? So we're not only trying to improve contractility, improve rate, but with these rhythms in particular, we're trying to improve the patient's responsiveness to the defibrillation that we're doing. All right, so we're going to start thinking about giving the epinephrine. And then again, after 2 more minutes of CPR or 5 more rounds, we can shock them again. But the third shock we deliver would be at 200 joules. And that's where we're going to max out on the number of joules that we deliver during defibrillation with a biphasic defibrillator. All right, so with this algorithm, again, still dead patient algorithm, so you still need to consider your H's and your T's. These rhythms have a higher survivability than asystole and PEA, right? The patient has nothing happening in the heart with asystole and PEA, and they have very, very, very poor outcomes. So that is why it is very much stressed to start considering your reversible causes, which are your H's and your T's. You still got to think about those with VFib and VTAC, but I'll tell you again, I threw a little nugget in there about a PE is usually the cause of asystole and PEA when the patient goes into VFib or pulseless VTAC. It's usually a big MI. So you want to think of thrombosis coronary. So that is your MI. That's it for our lesson today. Thanks for watching, and remember to check out our website at healthedsolutions.com for more free content or to get certified or recertified online.